inflammatory, chronic inflammation. It's very hard to figure out what's going on there. A lot of lymphoid cells, both probably macrophages and lymphocytes. This is a giant foreign body cell, granuloma. They're trying to surround whatever the heck this is. And as you can see, you've got this giant foreign body cell. Essentially, these are macrophages that have fused into one huge single cell. That's why they call it a giant foreign body cell. You've got a fibrous core around it, I should say some fibrin deposition around it. You'll have lymphocytes and fibroblasts around it. And, so this is sort of what you'd find if you tried to take this thing out, where you have T cells around it in the shell, you have the core with macrophages, the giant cell. So, this is a big, space-occupying mass, and the only way to get rid of something like this would probably be to remove it surgically. So if we take a look at where these inflammatory mediators come from, a lot of them are cell-derived, as we already pretty much mentioned. Histamine and serotonin are preformed in secretory granules, say from mast cells. Newly synthesized, they come from a number of different cells, such as leukocytes, mast cells, macrophages, etc. You've got things like platelet activating factor, leukotriene, prostaglandins, reactive oxygen species. So these are all newly synthesized upon stimulation of the cell. Now, lest you think you only get these things from immune system cells, you take a look here, excuse me, you see something that says EC. EC is endothelial cells. So endothelial cells, upon stimulation, can also make certain types of not only things like platelet activating factor and nitric oxide, they make a lot of cytokines. But that's not limited to endothelial cells. Under certain circumstances, depending upon the organ, you can find cytokines being produced by a wide range of tissues. That includes lung cells, liver cells, and I'm not talking about macrophages and endothelial cells in there. There are other cells that can produce these materials under stimulation. So be aware that under the proper conditions, you'll find cytokine and or chemokine production under inflammatory duress being produced by a wide variety of tissue cells. And indeed, if you look at the liver is makes quite a few materials. And if you take a look at the liver is actually the source of many of your complement components, as well as a lot of your clotting factors. So, be that as you may, you're getting a lot of your factors from many sources. Now, I mentioned that we would discuss the complement cascades. Complement, as I mentioned earlier, has one major function, but a lot of other accessory functions. The major function of the complement cascade is to blow holes in pathogens. That's one of the things it's designed to do. The other things that it's designed to do is to opsonize or make more delectable for eating pathogens and other things, and to make chemoattractants as it becomes activated. There are 3 recognized pathways for complement activation: the classical, the lectin, and the alternative. Now, of course, scientists being scientists, the classical pathway was the one that was indeed discovered first. That's the one that requires the production of antibody. However, it is probably the one that is actually least used by the body, only because, as you are probably well aware, it takes a while for you to generate antibody. The antibody, especially on first go-around, IgM takes what? Something like about a week to first show up. If you have a bacterial infection, you don't want to wait a week to first start to attack that. So you would use the lectin or alternative pathways, both of which use the pathogen surfaces to initiate the complement cascade. Now, in doing that, they do use a little bit different pathways than the classical pathway does to initiate this particular set of sequences. But what it does ultimately come down to is that they all come down to using what we call a C3 convertase. This is the place where the cascade actually begins to expand. So all of these proteins are circulating in your blood. Like I said, the complement proteins make up some 10% of your circulating plasma proteins. And for this to work, you start getting the activation on the bacterium, and then these proteins start to sit down on the bacterial surface and bind with the bacterial surface. And one molecule of the C3 convertase, as you can see, the C3 convertases is actually combinations of some of these other free proteins that have been split and put back together, can activate many, many, many other molecules of C3. Now, C3 is very important because C3 splits. So C3 splits into C3A and C3B. C3A is one of the two peptides that goes floating off and becomes a chemoattractant. So it's one of these things that says, okay, we've got a bacterial infection, please come and help. And the other part of it sits down and is part of C3b, and C3b will go ahead and bind with these other components, which is part of the C3 convertase, to become what we call a C5 convertase. And the C5 convertase causes the split of a C5, so the C5A goes floating off, and is actually even more potent chemoattractant. And this is going to bring in even more neutrophils, more macrophages. And these things are going to go ahead and, continue to bring in more and more and more phagocytes. Now, knowing this, so we've got these things down on the surface of the bacterium. These terminal components start lining up. C5b, 6, 7, 8, 9, a lot of nines. And essentially what that does is it makes a big hole in the bacterium. And you get enough of these big holes, and hence blows up the bacterium. And so you have many, many, many holes, many, many bacterium get attacked by the complement. Now, the other things that happen is that we get, because this thing is also sitting on the surface of the bacterium, it acts as like I said, an eat-me signal. It's an opsonization. It binds to receptors on phagocytes. So it sits there and says, okay, eat me, because I'm more palatable. It's another signal. It's an eat me signal. So these are the things that are necessary to be activated to further kill bacteria, to clean up the mess, as it were. So another thing that can happen, of course, put a splinter through your finger, you may be bleeding. We need to activate the coagulation cascade. Now, if you think the complement cascade is a little bit confusing, the full coagulation cascade is even more so. All of the materials that are involved in the true coagulation cascade would take up 3 slides worth of a table. So that's why I'm not giving them to you. Johns Hopkins actually has a really cool website that actually brings a lot of what happens into focus, so I strongly recommend you take a look at it. But, like I said, even this is incredibly simplistic. Even this is incredibly simplistic. But to make it a little bit easier, to bring it down, the coagulation cascade can indeed be started by bacterial components. Again, very important, because you may or may not have the tissue damage needed to initiate the coagulation cascade. However, there are 2 other pathways by which you can, the extrinsic and the intrinsic. With the extrinsic, you do have enough tissue damage. You go all the way down through the basement membrane of a blood vessel to expose something that's called tissue factor. With the intrinsic pathway, essentially you don't. You go just through the top layer of the endothelium within the blood vessel. So what the takeaway message is going to be from this very complex set of arrows and letters and numbers is the following. For this pathway to work, besides the initiating factors, it requires calcium. It requires phospholipids, and those phospholipids tend to come from platelets. And with all these factors involved, the intrinsic and extrinsic pathways come together at factor 10A. Actually, factor 10. Now, we have to have a limiting step here. And the limiting step here is the conversion of prothrombin to thrombin. This is your limiting step on making your clot. Because how much thrombin you have will determine how much fibrinogen gets converted into fibrin. So this is your limiting step. Now, of course, once you get your fibrin cross-linked polymer, you're looking at something that's going to be very tough. This is something that's designed to stop bleeding, designed to trap pathogens, prevent things from getting in, prevent things from getting out, making a framework indeed to prevent, to start healing. But sometimes you have to get rid of it, especially if it's in the wrong place at the wrong time. And I'm sure, how many of you, watch medical dramas? And how many of you have heard them yell, get the TPA? What's TPA? Tissue plasminogen activator. What's plasminogen? Plasminogen gets rid of the fibrin. So that's the target if you need to get rid of a clot. It's the plasminogen. That's one of the targets. There are other things, like I said, that will get rid of a clot, but that's one of the things that they use to get rid of a clot. And that's one of the things your body uses to get rid of a clot ultimately, to dissolve a clot. It's plasminogen. So These things, again, like the complement components, circulate in your body inactive. And if they spontaneously activate, they're actually, because they're so dilute, they get swept away and, disposed of. So, just quickly, I'm not going to belabor these because I'm sure Dr. Laskin brought a lot of these up. Some of the white blood cell products that are produced by neutrophils include the leukotrienes, proteases, reactive oxygen intermediates, things like thromboxane, which is part of the prostaglandin cycle, prostaglandin E2, things like hydrolases, myeloperoxidase. So basically, you're looking at something that's designed to kill. Monocytes, macrophages, and again, this is a very truncated list. Macrophages and monocytes produce some 50 known substances, never mind things that we don't know. And I'm sure Dr. Laskin said it's second only to the liver hepatocyte in its secretory processes. A whole host of cytokines, reactive oxygen and nitrogen species, and the like. Lymphocytes, of course, we're dealing with T helper cells. I've only listed 4 out of the now 9 known T helper paradigm cells. The T cytotoxics, and we have, of course, the B cells. Now, how many of you knew that there are now 9 recognized T helper subsets? I know we always usually deal with the Th1 and Th2, and we do probably mention the Tregs at some point, but there are now 9 recognized T helper subsets. And there's also a T0 that people are throwing around as well. Eosinophils, their main job is to kill parasites. Problem with eosinophils is when they end up in the wrong place at the wrong time, and they usually end up in pathological conditions like asthma when they end up in the airway and they don't belong there. They cause a lot of airway damage. But a lot of these materials that they have are designed to kill parasites. And if we look at the mast cells, and I'm sure we've done this ad infinitum, they've got things that are produced prior to their degranulation, things like histamine, serotonin, serine proteases. Histamine is usually conjugated to things in granules, and that includes things like heparin and other sorts of proteins, because you certainly don't want histamine floating around free inside your cell, but essentially you're looking at a very, very potent compound that has not only effects on the airway, but effects all over the body physiologically. And I'm certainly not going to give you my histamine lecture here because that would take me another hour and a half. So you don't want to do that. But you have histamine receptors all over your body, every places from your blood vessels to your gut, to your brain, to your immune system cells. And not only does it release histamine and these serine proteases, but a whole host of lipid mediators as well, which is what makes it such a potent foe once it degranulates and can cause problems systemically. Now, we did already hit upon the anti-inflammatory mediators somewhat. The fact that there are things like lipoxins, which are anti-inflammatory, some anti-inflammatory prostaglandins. These actually affect the switch that actually help turn off the inflammatory response. Now, one thing I did not mention when I showed you that little diagram is the fact that the things like the resolvins and the protectins and the merarcins are made from the omega-3 fatty acids. Anyone ever wonder why everybody says you need your omega-3s? Now you know. Omega-3 fatty acids are considered required as part of your diet, because you can't make too many, and that's the same with the precursors to the arachidonic acid. Your body also can't make that, so you need to get them from your diet. As far as other anti-inflammatory mediators, you've got certain cytokines, things like interleukin-1 receptor antagonist. Interleukin-1 is a very, very potent pro-inflammatory cytokine, responsible for turning on a whole host of inflammatory responses, including activating macrophages, activating T cells. Now, the interesting thing about these others is that they are both pro and anti-inflammatory. They've got double-edged sword possibilities to themselves. Things like interleukin-4 and interleukin-13 actually factor in very, very prominently in the pathogenesis of asthma, where they actually upregulate things like B-cell switching to IgE, increased mucus production. However, the other things that they do is they downregulate T-cell killing. They downregulate macrophage function. So that's why they call them part and parcel of anti-inflammatory. IL-10 is considered an anti-inflammatory cytokine. Again, it turns down macrophage function. Transforming growth factor beta, another one of these cytokines that turns off macrophage function. So despite the fact that a lot of these cytokines up here, the first listing of them, you'll see, oh, these are pro-inflammatory cytokines, perhaps with the exception of IL-10. What makes them anti-inflammatory is they tend to decrease macrophage activity. And if you decrease macrophage activity, almost by definition, you can decrease inflammatory activity. Like I said, despite the fact they do other things that increase other sorts of immune system function. So, in the last few minutes, let's look at tissue healing. We have tissue healing by first or second intention. Batteries are not dead, they're just out of position. So first intention, minimal or no tissue loss, minimal or no scarring. Think of a very minimal tissue scar, surgical scar, where you have a very, very nice scalpel line, very clean. You know, that's something you're looking at as far as the first intention type of healing. Second intention, you might want to think of maybe a burn or something where an ulcer, where you actually have some significant tissue loss, where you have the production of something that's called granulation tissue, and we'll go over that in a minute, where the healing is very slow and you have more significant scarring. So if we take a look at these images, and if you look at healing by first intention, you'll have scabbing, and so you'll have the migration of cells. I apologize for the fact that this is not working, so we'll have to go this way. Migration of cells into the area. Now it does say that we get some granulation tissue, but the granulation tissue, does that work a little better? Moment. Okay. So the granulation tissue that you get in first intention is very, very minimal, if you get any at all. So what you're getting are some fibroblasts coming in, some new blood vessels coming in, but again, you're looking at very, very, very small amounts coming in. And indeed, you get the reepithelialization of the skin here, and you get the fibrous union over here, and it's almost like there's a normal area. Now, like I said, is there a scar? There might be some, but the scarring is going to be incredibly minimal. In the case of second intention, as you notice, there's a larger area of loss of tissue. So there's a larger bridge through which the epithelial layer has to come. You have a larger number of macrophages and fibroblasts coming in, more blood vessels infiltrating, and these fibroblasts have to come in. Actually will have a wound contraction event coming in with the fibroblasts and the fibrous tissue, and this will definitely be a very visible scar compared to something like this. So once these collagen fibers mature, you will actually see this more visibly than something like this. So this is what granulation tissue would look like. We have this is the beginning of the healing process up here, and on the microscopic side, you see all of the macrophages coming in, the fibroblasts here. So the healing will progress. So lastly, in the last couple of minutes, you can have inflammation going on systemically. Of course, when you're ill, that's basically what's going on. And what's happening is you're dealing with systemic effects due to cytokines produced by your body. And this is usually by macrophages or T helper cells. When you have a fever, when you have the flu, that's not being caused by the bug. That's being caused by your immune system cells. All the yuckies you can blame your immune system cells for. If I injected you right now with gamma interferon, you'd feel like you had the flu. It has absolutely nothing to do with a virus per se, other than the fact the virus is initiating your cells, saying, okay, you got to fight me, so you're going to produce something. So what cytokines are we dealing with here? Tumor necrosis factor, interleukin-1 and interleukin-6. These types of cytokines are the pro-inflammatory cytokines that signal your body that something is wrong. You have an infection of some type. And in this case, most of the times, it's going to be viral. Can't say viral, because you can have some of these with bacterial as well. With interferon, but through interferon on there, it would be viral as well. Fever would you have the elevation of pulse and respiratory rate, elevated white cell count, acute phase response, so you'll get a rise in many proteins. However, what would happen also with the acute phase response is you get a decrease in albumin. Now what happens here is that your body is trying to make it unpalatable for the pathogens to live, not to make you miserable. You'll end up with anorexia, fatigue and sleepiness, malaise, pain in muscles and joints, and catabolism of lipids and proteins. Systemically, white blood cells, normally you have between 5 and 10,000 per cubic millimeter. It may double or triple. Neutrophils normally are about 70% circulating white blood cells. Those go up to 85%, of which as many as 12% may be immature. Lymphocytes are normally about 29%, and monocytes are usually about 2% circulating. Now, mind you, these percentages go down, but the absolute numbers will go up. Absolute numbers will go up. So we're looking at percentage here, not absolute numbers. We're just skewing. So if you have neutrophil numbers that skew like this, you could probably assume a bacterial infection, because there's really no reason for neutrophil numbers to peak if you're doing viral. You will have an increase in the red blood cell sedimentation rate, and your iron levels will decrease in the plasma. Remember, you're trying to make your body inhospitable to the bugs, and fever can have a number of causes, of course, You know, they're very wide and varied. Be aware that fever-producing substances include things like bacterial products as well as your own endogenous products. Something like tumor necrosis factor and interleukin-1 are considered endogenous pyrogens because they induce the production of prostaglandin E2 by other cells. Prostaglandin E2 is the substance that resets your hypothalamus to cause the fever. And that is that. Anyone has any questions? You may find me in my office most of the time. If it's not there, then in my lab.